So good morning. Welcome to PCEP for March 2023. Today we're going to review life threats in OBGYN. I welcome any questions. You can either raise your hand or put them into the chat and we'll address them as we go. So here's the outline of what we're going to cover today. We'll review the key points in assessment, and then I've structured this by age. So we'll talk about presentations in prepubescent females and women of reproductive age, talking about women who are possibly pregnant, not pregnant, and are pregnant. We'll talk about presentations in postmenopausal women, and then we'll talk about sexual assault. Key learning objectives here. I want to point out as we go through the few life threats that are associated with OBGYN complaints. We'll talk about ectopic pregnancy, we'll talk about complicated delivery, and we'll talk about shock. I want to review the management of complicated delivery. It's thankfully a rare presentation, but I think all the more reason that we need to think through it occasionally, both here and then in individual practice. And then we'll talk about other OBGYN presentations. I want to emphasize things that have changed since we last did this lecture, and just give you general information to be proficient healthcare providers. So a brief review of assessment. What are the key points? Isn't anything, we get the HPI and the characteristics of the pain are really helpful. Getting some quantification of the bleeding or discharge and frequency and amount. Usually the easiest way to ask that is just to get a rough estimate of the number of pads used and whether they're soaked or spotted. And then last menstrual period is a key portion of the history. It looks like someone is muting me. I know I'm not the best, but if you give me a chance, I promise I'll get through this as quickly as I can. So with past medical history, the G's and the P's, how many times has the patient been pregnant? How many times has the patient given birth? Especially an OB presentation gives you a lot of information about how quickly things might move along. Other reproductive disorders, and then other surgical history. You know, has there been a hysterectomy? Has there been a tubal ligation? You know, but remember that a tubal ligation doesn't mean that pregnancy is impossible. People still can get pregnant and are more likely to have ectopic pregnancies if they are pregnant after a tubal ligation. The physical exam is limited. The vital signs are really the most key finding here. Just like with other presentations of abdominal pain, the vital signs are the most reliable clue to what's going on. But it is in the pre-hospital setting when you can, a limited visual exam can be helpful. Obviously, with OB presentations, you have to know if the patient's crowning or not, and getting some sense of what's going on with hemorrhage. But if you do that, please have and document having a witness. A witness, a chaperone. It's not an exam that one person should do by themselves, even if it's a female provider. So with prepubescent females, there are just a handful of things that we need to think about. So in the first week of life, females can have vaginal bleeding. It's from withdrawal of the hormones that they were exposed to during pregnancy. It's not dangerous, but that said, it's very concerning to parents. Those are cases where if the other history is really reassuring, you could consider leaving at home with a medical control consult. But the vast majority of these, because we have to consider trauma and other problems as well, require an ED evaluation. And to be clear, that's really that hormonal withdrawal bleeding is only in the first week of life. You have to consider foreign body. We have to consider trauma and abuse, and then more rarely malignancy. So as a general rule of thumb, prepubescent females with vaginal bleeding, vaginal pain require an evaluation in the emergency department. In women of reproductive age, we'll talk about first people who could be pregnant. You don't have definitive information saying that they are pregnant or not pregnant. And so we have to think about the first trimester emergencies: ectopic pregnancy, spontaneous abortion, septic abortion. So with ectopic pregnancy, that's pregnancy implanting anywhere other than in the uterus. So most of these are in the fallopian tube, but they can be abdominal. They can be in the adnexa here next to the ovary. They most commonly present approximately 6 to 8 weeks after the last menstrual period. Risk factors for an ectopic pregnancy are having had a prior ectopic pregnancy. In vitro fertilization puts you at risk for ectopic pregnancy, and those are the rare cases that can have what's called heterotopic pregnancy, where you both have an intrauterine pregnancy and then you also have an ectopic pregnancy as well. Really outside of in vitro fertilization, that doesn't happen. Having had previous gynecological surgery, that can include a tubal ligation, other procedures, puts women at higher risk for ectopic pregnancy. And having an IUD, although it's really effective birth control, if patients do become pregnant on an IUD, there's a higher risk of an ectopic pregnancy because of the device inside the uterus. Somewhat lower risk factors, having had previous pelvic inflammatory disease and smoking, also place patients at higher risk for an ectopic pregnancy. It is important to know that you may be coming up on someone in the field who has been diagnosed with an ectopic pregnancy and has received methotrexate, either in the OB/GYN clinic or in the emergency department. Those, to be an appropriate candidate for methotrexate, they need to be relatively small ectopic pregnancies that are relatively early on, but they still can rupture and can become ill. So those are patients that you could encounter in the field. As you mentioned, 95% of ectopic pregnancies are in the fallopian tubes. Until we have confirmation of an intrauterine pregnancy, which means that either they went to their OB office or they went to the emergency department, they got an ultrasound showing that there's a pregnancy inside the uterus and they're not on IVF, we have to assume that a woman who's pregnant has an ectopic pregnancy. And so most ectopic pregnancies are stable for some time, and then there's a rupture. And that typically causes severe pain, causes hypotension. And one of the clinically weird things about that is it's one of the few types of hemorrhagic shock where patients can present with bradycardia. Our best guess is that that is blood irritating the vagal nerve in the abdomen, but no one really knows for sure. But it's something you can see these patients who are like, the pressure is 60/40 and they have a heart rate of 50, rather than the tachycardia you typically expect to see with hemorrhagic shock. You can also see them tachycardic, but I will say in my clinical experience, I've more often seen them be bradycardic than tachycardic. Okay. Spontaneous abortion is loss of a pregnancy without any other procedure. So it's presents with vaginal bleeding or abdominal pain in a pregnant female. So you can have what's called the threatened abortion, where you have bleeding, but the cervix remains closed. And so, one thing that I'll tell my patients in the emergency department is patients who have vaginal bleeding in early pregnancy, the most likely outcome of vaginal bleeding in early pregnancy is a normal pregnancy. It's obviously very nerve-wracking, but this is something that we see very frequently in the emergency department. Once the cervix opens, then that's what's called an inevitable abortion, meaning that whether it's happened completely or not, that pregnancy will be lost. You can also see an incomplete abortion where the cervix is open and the fetus has started to pass but has not passed. And so generally, as women get further along in gestational age, the hemodynamic significance of a spontaneous abortion increases. So, people rarely get sick from, say a pregnancy loss at like 8 weeks, 12 weeks, but at 15 weeks, 16 weeks, that's something that can make someone quite hypotensive because of the associated blood loss, and there could be significant pain associated with that. And then the last thing that I want to mention is septic abortion. This can happen after a spontaneous abortion, but it's in less than 1% of cases. After a medication abortion, less than 1% of cases. If there's a therapeutic abortion done by a physician in a safe environment, again, less than 1% of cases. If there is an unsafe abortion, meaning something done outside of a healthcare setting, the risk is about 5%. And so these are patients that have some products of conception still inside the uterus. They typically have fever, pelvic pain, and a foul smelling discharge, and they can get quite systemically ill. Now we're going to move on to diagnoses that we see in women that are not pregnant. I just want to make sure I'm not missing anything in the chat. Okay. Okay, so we're going to talk about ovarian torsion, ovarian cyst, abnormal uterine bleeding, sexually transmitted infections, toxic shock syndrome, pelvic organ prolapse, and then I'll throw in a brief discussion of some other non-emergent diagnoses. So ovarian torsion in women who are not pregnant is probably the top of the list of the things that we want to pick up quickly. Essentially, time is ovary because you're talking about an ischemic ovary in this situation. So it can occur in all ages, even in prepubescent females, but the most common is in the late 20s, early 30s. Anything that makes the ovary bigger puts patients at higher risk for this. So having a mass, having had a prior torsion, having had prior large cysts, patients with polycystic ovarian syndrome are higher risk for this because they tend to have cysts. And so what happens is that the ovary twists on its blood supply and becomes ischemic. It's a version of the same thing that happens in testicular torsion. So the onset often sudden and severe, but it can be this intermittent pain because it can torse and untorse and torse and untorse. So it can be a really difficult diagnosis to make. It is often associated with nausea and vomiting, and so in some way it looks kind of like the pain that you see with kidney stones, like this kind of intense intermittent colicky pain that causes nausea and vomiting. And so this is a schematic of what happens with the twisted ovary, and then this picture below is a laparoscopic image of a twisted ovary that's become ischemic. So time is ovary, and so when you're counseling patients, especially with this intermittent severe pain, especially anyone who has risk factors, these are patients that we want to see because the best way to sort this out is with a pelvic ultrasound that looks at the blood flow to the ovary. And it is definitely a time-sensitive diagnosis. Ruptured ovarian cysts are less time-sensitive, but rarely, but they can make patients hemodynamically unstable. So the risk factors are having a known cyst or mass. Obviously, they tend to be more significant if there's thrombocytopenia or anticoagulation. They can occur during intercourse, and they also tend to be this fairly sudden onset of pain, but then the pain tends to persist, and then they can have this hemoperitoneum and have that same irritation and the peritonitis from the blood in the peritoneum. So again, on the top is schematic of the cyst rupturing, and then another laparoscopic image of the cyst with blood in the peritoneum. The vast majority of ovarian cysts do not rupture. And even of the ones that do rupture, it's a fairly small number that cause hemodynamic compromise. But again, higher risk if there's a bleeding disorder. So I'm going to quickly review abnormal uterine bleeding. You may have heard a bunch of other names for this in the past, dysfunctional uterine bleeding, and then there were other terms like menorrhagia, metromenorrhagia, that are kind of hard to remember and less helpful. So this table, which is from UpToDate, kind of defines what's normal and what's abnormal. Certainly don't need to remember this, but what I would take away from this is the key point is just getting history, how frequent, what's the duration, how regular, what's the flow volume, and then how intermittent is it. Abnormal uterine bleeding, again, in women that are not pregnant, is rarely dangerous, but it can really be interrupt a woman's life and be problematic. And again, until we know that the woman is not pregnant, we have to consider ectopic pregnancy. We can also see pelvic organ prolapse. So the risk factors for this, having given birth multiple times, especially multiple vaginal deliveries, the risk increases with age, risk increases after menopause, and then the risk increases with obesity. So you can have cystocele where the bladder prolapses, you can have prolapse of the uterus, prolapse of the rectum, or even prolapse of the intestines. And again, this is something where just, if you can get the patient in a private environment, a quick look just to see there's something sticking out there is helpful for figuring out where the patient needs to go in the emergency department. Past that, you don't need to differentiate any further. So I want to talk about sexually transmitted infections and then how they progress. So a relatively mild, uncomplicated sexually transmitted infection is cervicitis, where there's just inflammation around the cervix. That's something that we'll see on a pelvic exam. You can then get endometritis, where the whole uterus gets affected, and then that's a generalized pelvic inflammatory disease. These patients are really tender on the pelvic exam. That can develop into a tubo-ovarian abscess, which usually requires admission and occasionally requires surgery for drainage. So that's usually somewhere in the tube, they'll develop an abscess, and then those can rupture and they can develop peritonitis and to be quite sick generally. Again, vital signs are the key things that are going to let you know how sick a patient is in this situation. Toxic shock syndrome is something we still do talk about because it can occur. Not unlike me, probably peaked around 1980. And this is when these super absorbent tampons came out. It's much less common than it used to be because there's more awareness of it, but it is still something that can happen. And so it happens with continuous tampon use. It can occur in non-menstrual cases, like with a surgical or a postpartum wound infection. And there's this staphylococcal scalded skin syndrome, but they're going to look obviously ill. They have this red skin. They can have sloughing of the skin, and then they tend to be really hypotensive. Again, your vital signs and then the skin exam are going to be the clues here. So mention a couple of non-emergent diagnoses. So Mittelschmerz literally is German for pain in the middle. It's just pain in the middle of the cycle around the time that the egg is released. Endometriosis is a condition of having endometrial tissue, the tissue that's normally in the uterus, somewhere outside of the uterus. In general, can be painful, but doesn't cause emergencies. The one exception to that is what's called a catamenial pneumothorax. So you can get this endometrial tissue in the lining of the lungs. And so there are women who have their period, and then after the start of their period, they get a pneumothorax because this tissue expands and it's in the pleural cavity. And and then the pleura separates and they get a pneumothorax. Some people obviously will have had this happen before and know, but sometimes you can see a first presentation of that. Uterine fibroids are painful, can cause bleeding, but they're not associated with emergencies. Okay. Now we'll go into emergencies that appear in pregnant women. We talked about ectopic pregnancy, spontaneous abortion, and septic abortion that you see in the first trimester. Make a brief mention of things that we see in the second trimester. As I mentioned, as the size of the gestation increases, the hemodynamic significance of a spontaneous abortion increases. So, and really past 12 weeks, once you really once you get into that second trimester, typically a pregnancy loss is associated with a lot of pain and a lot of bleeding. If possible, if they've passed tissue at home, it is helpful to bring the products of conception in, because there is some testing that can be done just to understand better what happened. Okay. And then as we get into the third trimester, probably the most critical thing is to remember that these are patients that should be transported and resuscitated left lateral recumbent, because you want to get the fetus off the inferior vena cava, so you can have good venous return to the heart. And so especially in a hypotensive pregnant patient in the third trimester, you're going to relieve that by tilting the patient onto the left side. How do you know if someone's in the third trimester if they haven't had dating? A good clinical rule of thumb for if someone's at a viable, has a viable pregnancy is the fundus of the uterus past the umbilicus. Once it gets past the umbilicus, you're likely dealing with a viable pregnancy. In the third trimester and up to 6 weeks postpartum, we have to think about pre-eclampsia and eclampsia. So it's something where we'd evaluate further if the blood pressure is over 140/90. They really start to get into danger. Blood pressure is greater than 160 systolic or 110 diastolic. They typically present with headache, can have confusion. They will often have visual disturbances. Occasionally, they can have epigastric pain or dyspnea. And so pregnant women that are seizing, we still use midazolam first line because we want to terminate the seizure as quickly as we can. So 2.5 to 5 milligrams IV or IM, Q5 minutes as needed. But we do want to also make sure that we load them with magnesium, 2 to 4 grams IV over 20 minutes. And that will help to prevent further seizures. I'm going to do a quick review of normal childbirth. So remember, gentle counter pressure as the woman is pressing. Sweep your fingers around, check for a nuchal cord. If there are copious secretions, you can wipe the nose and the mouth. We no longer routinely do suctioning. In a normal delivery, you'll clamp and cut the cord about 30 to 60 seconds after delivery, 6 inches from the infant. If you need to resuscitate the infant, clamp and cut immediately. Dry the infant, place on the mother's chest unless there's some contraindication, and document your APGAR scores at 1 and at 5 minutes, and just describe in your chart what you saw. Okay, so abnormal childbirth. First thing we think about is a breech presentation. So that's a presentation of anything other than the head as the presenting part. You do allow the mother to push, support any body parts that have been delivered. If say you have a fetus that's partially delivered but the head's not delivered, you can use your fingers to kind of create a V around the nose and mouth and create some space for the infant to breathe. These are obviously require rapid transport. And I think one of these, probably the most difficult, is when you just have a single foot presenting, because it's really unlikely that the rest will deliver well. If you have just a single foot presenting, you can try to help deliver the second foot, but the key to these is rapid transport and letting the hospital know what you have. You can see a prolapsed umbilical cord, where the umbilical cord itself is the presenting part. So in situations like that, you want to put the mother either in a knee chest position or in an extreme Trendelenburg, trying to take some pressure off the cord. And then you want to lift either the head or the infant's body off the cord. If you're doing, if what you're doing is working, you're going to feel pulsations going through the cord. And this is a situation where once you have your hands in there, you're going to continue in that position until you're relieved by someone at the hospital. This is often a situation where you need to have a provider up on the gurney to continue to relieve the pressure on the umbilical cord. Okay. And nuchal cord, that's when the cord is around the infant's neck. So the first maneuver is to use 2 fingers and to try to deliver it. You can try to deliver it first over the anterior shoulder, the shoulder that's presenting. If that doesn't work, you can try to deliver it over the posterior shoulder. If neither of those work, then you want to clamp and cut the cord so the cord is not strangling the infant. And then one of the most common problems with delivery is shoulder dystocia. And so, gentle downward pressure from the outside can help. And then the McRoberts maneuver, where you're taking the mother's knees and helping them push them back towards the chest, that can create some more space to try to help deliver that shoulder. And I'll just one brief comment. As I mentioned before, I mean, these are obviously rare things that we deal with, and so I find that it's helpful just every now and then to think through, okay, what would I do in this situation, especially when you're going on an OB call. Just think through, what would you do in a normal delivery, what would you do in an abnormal delivery. Even just having that mental rehearsal can give you a small advantage when you're going into these difficult situations. Okay, postpartum complications. Major one is hemorrhage. So postpartum hemorrhage is the cause of about 1/4 of pregnancy-related deaths. It can happen immediately after pregnancy, but it can be delayed. Rarely past 4 weeks, but there's often a period around 2 weeks where women are at higher risk for having postpartum bleeding. So if you're dealing with it immediately after delivery, it can be, most common thing is that the uterus is just atonal, hasn't contracted down yet. There can be laceration or retained placental tissues, uterine inversion, coagulopathy. But the key thing immediately after delivery is to do that firm, steady uterine massage to try to get the uterus to contract. It's more likely if there's a difficult placental delivery, if you feel the uterus and this hasn't started to contract, those are patients that are more likely to bleed. And patients who do have a vaginal delivery after a prior C-section or have had other uterine surgery are at higher risk for rupture. So other than the uterine massage, O2 IV with volume support, if you do have a midwife on scene, they also have medications that can help with postpartum hemorrhage. And then last comment about cardiac arrest in the 3rd trimester. As before, key thing is to displace the uterus to the patient's left to try to get the pressure off the inferior vena cava. And then this is not something that we have a protocol for because this is a relatively rare situation. I'm only aware of 2 of these in the 10 years that I've been here. But if you are close to a hospital and the mother goes into cardiac arrest, in the hospital, we have the option of doing a perimortem C-section, but we really have 4 minutes from the time that the mother loses pulses to get the fetus out to have a chance at a successful outcome. So it really is only relevant if you have a brief transport between the time the mother loses pulses and you can get to one of the hospitals. But both of the hospitals have good OB support, and that's something that, although emergency physicians are trained to do, we'd be happy to defer to our OB colleagues. But that's something where they can, an experienced provider can deliver in less than a minute with a perimortem C-section, and that both gives the fetus a chance for survival and also is typically the mother's best chance for survival, because that you're taking all the blood that was diverted to the fetus and then getting that back to the mother. Any questions so far? Okay. So I'll continue on just a few points about postmenopausal women. So unless that patient is anticoagulated, vaginal bleeding is rarely life-threatening in postmenopausal women. The biggest thing we have to worry about in postmenopausal women is malignancy with presentation of vaginal bleeding. And I think all of us have a tendency to forget about the possibility of sexually transmitted infection. But for better or worse, nursing homes are actually a relatively high area of transmission sites for sexually transmitted infection. So those are things that still need to remain in the differential for older women presenting with GYN complaints. Finally, we'll talk about sexual assault. So in the US, lifetime incidence of sexual assault is 27% in women, 2% in men over the course of a lifetime. It is estimated that as few in 1 in 3 cases are reported. Patients that are in racial, ethnic, or sexual minorities, such as lesbian, gay, bisexual, or trans, are disproportionately affected by sexual assault. Genital injuries in sexual assault are relatively rare, but they commonly have other injuries, especially facial injuries, but have truncal injuries as well. And I think one of the things, as we see these cases in the emergency department, one of the things that's most frustrating for especially parents in a pediatric sexual assault is like they want to believe that we can look and say, oh, this is what happened or this didn't happen. And unfortunately, that's rarely possible in an emergency department exam. There's just no, unless it's very, very obvious, there are very few exam findings that make it clear what happened. So how do we approach these cases? It's very important to address the physical and the psychological well-being first, and to take a non-judgmental approach. And what we tell these patients, especially those patients that are on the fence about going to the emergency department, there are two purposes to the ED visit. So one is that we find and treat medical emergencies, which is important, and we can give prophylaxis against sexually transmitted infections, against unwanted pregnancy. And this is relatively unique to any presentation. The other thing that we can offer in the emergency department is that we can collect evidence of a crime. And in most cases, this is done by a specially trained sexual assault nurse examiner. Remember that the patient does not need to decide at the time of the evidence collection whether they want to report the incident to police, but they only have that relatively small amount of time, typically 3 days after the assault, where they can have evidence collected that can ultimately be used in court. Encourage patients to preserve evidence. So it's common to have, understandable to have the desire to take a shower, take everything off. But this is a case where it's better if the patient comes in wearing the clothes that they were wearing at the time. And then other than that, supportive care as necessary. So any other questions before I go on to the take-home points? Okay. So we talked about presentations in prepubescent females. I would say have a low threshold to consider abuse and trauma. Those can be really difficult to sort out, and have a low threshold to bring these patients into the emergency department. In women of reproductive age, consider ectopic pregnancy unless we have definitive evidence otherwise. Whenever you can, think through the mechanics of pre-hospital delivery. And then, as I've mentioned several times throughout, in OB/GYN emergencies, vital signs are going to be the best key to guide your treatment. With that, I will wrap up. I'm going to I'll put this link for feedback in the chat as well, where you can scan the QR code. It should be with your quiz also, but really do value your feedback. We want to make these sessions as valuable as possible. Other questions for me?
Thank you, Dr. Mock. I'm going to I'll leave the meeting open for roughly 5 minutes in case so people have a chance to scan that code and give some feedback.
Okay. And I'll stay on if there are any questions. You can also hit me by email. But I'm grateful for your time and attention.